Good morning, guys. Thank you so much for the opportunity to speak with you today. Can someone tell me how much time I have? Because I know we're running a little late. I don't want to throw off your entire thing. Okay, I am going to share my screen then. I saw that somebody said I have as much time as I want. I hope you don't regret that. So I am just going to give an overview of kind of things that are going on that I was told, might help you guys. And I would love to hear your questions. And as you're listening to me talk, please think of your questions and also any ideas or recommendations for how I can help you guys personally or how the Utah Department of Health and Response can help you do the awesome work you're doing. I can't thank you enough. So first, I just want to give a quick little overview of how COVID is actually spread. I know this has been really confusing because the science hasn't changed, but the information we've learned about COVID has increased from the beginning. So there are two ways that COVID spreads. One is droplets. So droplets are those kind of big saliva droplets that come out when you sneeze or cough. And they don't tend to travel very far. So they don't stay in the air very long and they don't go very far. So that's where physical distancing really helps. And that's where masks really help as well, because a lot of masks can stop those big droplets. So the way it transmits is if somebody isn't wearing a mask or you're close to someone who coughs or sneezes, the droplet gets on you and it gets in your mouth or nose, and then you have the virus inside of you as well. The other way it spreads is by airborne transmission. So this is where they're really small particles, and they can be, these kind of small droplets can be released just by talking. This is where kind of that evidence around choirs spreading it or people talking more loudly tend to have more of these droplets go out. This is where they can travel much further than potentially 6 feet, and they stay suspended in the air longer. Some masks can stop some of this from spreading, but definitely not all of it. That's why masks aren't 100% prevention, and social distancing really helps with the prevention. So those are the two ways. We think that most of the spread is by droplets, so when we're close together and people are coughing or sneezing, but there is evidence of this airborne transmission as well. So, we get this question a lot, and I'm sure you do too, like, why are we making such a big deal about COVID? Isn't it just like the flu? Well, here's our latest data. You've got the first row COVID data as of December 9th, which was yesterday. The second row is our influenza data from 2017, 2018. And note, this was a really bad flu season. So most of our flu seasons aren't this bad, but I'm comparing COVID to one of the worst flu seasons we've had in recent history. You can see we have less cases of COVID. However, our hospitalizations are, more than 4 times as we have with flu. And our deaths are significantly higher due to COVID than the flu. So it is more dangerous than flu. And the key difference too is the difference between treatment and vaccines. Currently, we're improving this, but there's no cure for COVID. All the treatments we have so far are limiting the symptoms or limiting the duration of the disease, but it's not removing the virus from the body. Flu, we have 4 treatments, right? It's been around longer, so that makes sense that we have more treatments. Vaccines, and again, this is hopefully changing today for the US, but we currently don't have a flu vaccine, and I'll get to where we are with that later. But we've had flu vaccines every year, and so it really makes it easier to control flu every single year versus COVID. So this is where we are currently in our outbreak. The orange bars mean we're increasing in cases, the yellow means we're plateauing, and the blue means we're decreasing. So you can see we had a huge increase that started in the beginning of fall. That was largely with universities and schools going back in session, started within that young community and then spread to the broader community. And then of course we hit winter where people are inside more and we have holidays. Luckily, we are not continuing to see this huge surge. It hasn't been that long, so it's hard to put a lot of confidence in that, but it's certainly a good thing that we're not continuing to see this up. This is our hospitalization data. So throughout this outbreak, about 5% of all of our cases become hospitalized. And it usually, after we see a surge in cases, usually about 2 weeks later, we see a surge in hospitalization. People tend to become hospitalized about 10 days into their illness. And so you can see this has followed exactly that other curve. So we've got our peak starting in September, and then our peak of hospitalization starting around October. Today, 93.4%, so around 93% of our ICU beds at our referral hospitals are occupied. Referral hospitals are those 16 hospitals where if you've got COVID, that's where you're gonna go get treatment because they're able to provide the best treatment for COVID. And we essentially are at capacity for those beds today. And the same follows, we have about 1% of all of our cases end up passing away or dying from COVID-19. And that happens about 4 to 8 weeks after we see a surge in our cases. And again, the data is holding true here. Our surge happened at the beginning of the fall. And now we are seeing more than 20 deaths every single day, which is just tragic. So you guys are super important in this. We need community health workers because at the very beginning of this, and history tells us that whenever there's a pandemic, our under-resourced communities and communities of color tend to be the hardest hit. And that is true for this pandemic. So this is a map of Salt Lake County. I-15 divides it in half, right? The red means you have a higher risk of becoming infected with COVID. The lighter yellow and orange means you have a lower risk. If you live west of I-15, you're twice as likely to be infected with COVID than if you live east, just by where you live. We also found that 3 sectors have the majority of our workplaces, right? Wholesale trade, manufacturing, and construction. And 73% of all of our workplace cases are Hispanic or non-white, whereas only 24% of our workers are Hispanic or non-white, right? So this is just highlighting that, COVID has really magnified the health disparities that have been ingrained, as you know, in our society for decades. We have a health improvement index, which is basically a composite metric of social determinants of health. And this is a graph. Green means very low health improvement index, meaning they tend to have higher socioeconomic status, higher education, bigger houses, those sorts of things. The high health improvement index are under-resourced communities. And at the beginning of our outbreak in March, this is March, you can see our cases are highest in our very low or low health improvement geographies. And I'm just gonna scale through, so over time, watch how these bars change. So this is over time of the outbreak. We start to see more cases in our very high and high areas. And this is August, and this is when it has definitely shifted. The burden of disease has shifted from the very low and low health improvement index geographies to the very high. And I know you guys know this. It's just striking to me every time I see the kind of time lapse of this. This outbreak started in Utah, in Park City during ski season. Our first cases were individuals who were on international cruises or traveling internationally or here for ski vacation. And that really showed where it was in our very low health improvement index. And then very quickly over time, the burden of disease shifted to our more vulnerable populations. And now, of course, wherever we have geographies that have a very high health improvement index, they have a high case rate. And this just highlights the importance of the community health workers in the response of not only COVID-19, but you guys are proving that it is so necessary to have community health workers part of every public health response, not just COVID. And we've seen the great work you've done in the numbers. Of course, I'm an epidemiologist, so we always look at numbers. At the height of our outbreak, our Hispanic population is only 14% of the Utah population, but had over 50% of our cases. With the great work you've been doing, you've been able to drop that, which is just fantastic. And the same has happened with our Native, Hawaiian, and Pacific Islanders. They're about 1.3% of our population, and at the peak, they were nearly 7% of our cases. And once again, the great work you have done has made a difference. I was asked to kind of give a little update of what's going on. I know there's, the only constant is change in this pandemic, and we have changed our quarantine recommendations. This graphic is on our website, but I just want to kind of give you the overview and allow you to ask questions if you're still confused, because it's so important that you have the right information to pass along. The incubation period of a disease is, of course, that time from when you're exposed to when you can get sick. And that incubation period, so the maximum amount of time that from when you're exposed to when you'll get it, if you do get it, is 14 days. So that's why we ask people who are exposed to stay home for 14 days, because if they weren't sick after 14 days, they wouldn't get sick. However, that's a huge burden for people to ask them to stay home for 2 weeks. And in an effort to decrease the burden of quarantine, but also keep people safe, so that balance, right? The CDC has recommended now a 10-day quarantine, because that last 4 days is really a small percentage of the population. So we capture about, if you're going to become sick with COVID after you're exposed, about 80% of the people will become positive around day 10. And so you're only missing a really small fraction in those last 4 days. So people who end quarantine early still have a chance of becoming COVID positive. So it's really important for them to still wear their mask all the time, but also be very aware of their symptoms and isolate the moment they feel any mild symptoms at all, because they still are at risk, but it's a low risk. And so we want to be able to decrease that burden of quarantine, but they still should be aware that they're not home free after 10 days. In further efforts to decrease the risk, to decrease the burden of quarantine, people can even shorten their quarantine further if they have a negative test on day 7 of their quarantine. So if you test negative on day 7, you're unlikely, it's still about that 80%, to become positive in the next week. So a negative test on day 7, you can end your quarantine, but once again, please pass along the information that it does not mean that they're at no risk. It's still very important for that last week to be really mindful of their symptoms and isolate immediately. The last thing I'll talk about is, of course, the vaccine. Today, the FDA is meeting to hopefully approve the Pfizer vaccine. I assume that they will, given that Canada and the UK already have. If they approve it, it will then go to the ACIP, which is an immunizations recommendation body with the CDC, and they'll make specific recommendations for the Pfizer vaccine on how to use it. They're going to meet tomorrow, so we can anticipate vaccine being shipped to Utah early next week or over this weekend, with hopefully the first shots in arms by the end of next week, which is so exciting, and it should be for everybody. I will say that there is, of course, priorities. So we are not getting enough vaccine for everybody. We're getting somewhere around 100,000 doses, and remember that everybody needs 2 doses of the Pfizer vaccine in order to have sustained immunity. So our phase 1 is going to be in the winter, December to February, and we're really going to be targeting those at highest risk for being exposed to the virus or for becoming really sick, right? So that's going to be our frontline workers and healthcare workers, and that's also going to be individuals who live in long-term care facilities, because they're at the highest risk for dying. Because our governor is very adamant that we have kids in school, K through 12 educators and school staff will be included in there as well. And Tessa, this reminds me, we should talk about our community health workers considered frontline health staff, and talk to Rich about that if you haven't already. So yeah, we should remember that, Tessa.
Yeah, absolutely.
My sense is they are, because it's like anybody who interacts with the general public on the front line. So home health is included in there. There's a lot of different sectors. So let's just make sure they're line itemed in there, so we can, because it's also such a small number, right? Okay, let's remember that. And then once we get to the spring, we're hopefully going to have a lot more vaccine and start being able to offer it to the general public. If we don't have enough initially, we're still going to have to figure out who within the general population should get the vaccine before others. That conversation hasn't gone into a lot of detail yet. There's consideration about targeting, individuals over 65 or others. but that kind of that green piece just isn't completely flushed out yet. We might still have to prioritize. And then this summer, we're anticipating anybody being able to go to a pharmacy or your primary care provider and actually get the vaccine. I will say, you guys are going to have a huge, huge role in this. We know the communities you serve historically have lower uptakes of vaccinations, obviously lower trust of the government. And so we're going to be relying on you to get the word out to the community that it is safe and necessary for them to protect themselves and their community to get the vaccine. And I would love to dialogue with you guys about the best information we can give you that you feel comfortable making that recommendation to the communities you serve. The last thing we need is, another obvious health disparity when it comes to vaccine distribution. We want to make sure that the communities you serve are right there, able to access the vaccine as much as everybody else. That is all the information I have. I would love to take questions if we have time. I'm happy to do so.
Doctor, there is a question in the chat. If the vaccine is going to be free?
Yep, absolutely. The vaccine is going to be completely free for everybody, no insurance, at this point, I haven't heard anything about, checking citizenship status. So that is something we will have to make sure. It'll be similar to testing, but we'll have to make sure that that message gets out.
There is another one that it says, what are the chances of getting COVID more than once?
That is something we are still learning. We do have evidence of reinfection. It generally happens after 3 months or more, but that is still, given that, we just discovered the virus, less than a year ago, it's something we're still looking into. And when I say we, it's the broader public health and science world. So very small. So I would say the chances are really, really rare, but there is evidence.
Is there a special protocol in between the doses of the vaccine?
Yeah, so it depends on the vaccine, but I will tell you the Pfizer vaccine is to be 21 days apart, and people are thought to be immune 2 weeks after their second dose. The Moderna vaccine, which isn't approved yet, I think is a 4-week lag between the two.
Yeah, there is another question from Jessica. How long has this vaccine been tested? And how do we know what are the possible long-term side effects?
Yeah, absolutely. I mean, this vaccine was pushed really quickly. It did not skirt any of the FDA rules. So whenever FDA has 3 phases when they do vaccination trials. So the first phase is safety, the second phase is efficacy, and then third phase is safety and efficacy. So it is safe for the general healthy public. It has a similar side effects as other vaccines. So, individuals who have, as we've heard from the UK, who have severe allergic reactions might have another severe allergic reaction to this vaccine. That's common for all vaccines. In terms of long-term effects, we clearly won't know, right? Because it's been studied for two months out. So individuals who have been fine 2 months out. But time will tell. I can tell you that the initial data coming out is very similar safety profile to all the other vaccines we have, so we don't anticipate any long-term effects. So me personally, the benefits of getting the COVID vaccine outweigh the risks.
Okay, there are so many questions. I will try to go over. It says, what is your biggest challenge as a healthcare worker?
So I don't actually see individual patients. My job is to advise on the strategy for how we respond to the pandemic and the policies in place. So my biggest challenge is 100% trying to educate individuals who aren't in the healthcare space, but who are in charge of making decisions about this pandemic. So it feels like it's public health 101 every day, and really trying to help people understand the best way forward.
Jeffrey said, what are the chances of the CHWs who are in rural areas receiving the vaccine?
Oh man, you hit a great point. Rural areas in general for the Pfizer vaccine, everywhere across the nation, are tougher to get to because the Pfizer vaccine requires super cold storage. It's not called super cold, forget, but it's negative 80 degrees Fahrenheit that it has to be stored. Specific freezers, specific cold chain, which makes it more difficult in the transportation to rural areas. Our immunizations program is working really hard on that, and how they're doing that is working with hospitals across the state to have those freezers in place so that it's not all on the Wasatch Front. And so that actually logistics and process chain is still to be worked out, but it is on the top of our mind.
Okay, we have time for one more question. Let's see. I'm scrolling over here.
Okay, sure.
It says, Dr. Dunn, when can we expect an in-depth conversation with you to have as much information about the vaccine so the CHWs can ensure we provide the truthful, complete information to the community members outside?
Yeah, we need to do that. And Tessa, it would be great. I had a brief conversation with Dulce, I don't know if she's on the phone, about, we need to start focusing on our most vulnerable populations and getting information out. And you guys will be key in helping us craft that. So we've got time, given that, we probably won't have vaccine for people outside of the workforce until March. But it is something we should start planning now and maybe start campaigning after the new year. So Tessa, if we could work together with Dulce and figure out that best way, that'd be great.
Yeah, definitely, guys. We are on it. I've talked to Rich a little bit about it too. So we are kind of planning that training, because we completely agree. It's not fair to ask you to promote something like this that you don't feel comfortable with and that you don't maybe fully understand or have all the facts. So we really are working on getting that to you guys. So thank you for that.
And Tessa, there's actually a webinar tomorrow on the Pfizer vaccine. I'll send it to you. It might be good if you listen to it too, so you and I at least can both understand everything about it. Okay. Thank you so much. You guys, this has been fantastic. I love speaking with different people, especially, honestly, you are so key to our response. Thank you. Thank you. If there's anything I can ever do or we can do better, please don't hesitate to reach out. I really appreciate everything you're doing. Happy holidays, guys.